All right, what's up, everybody? Your boys are back. So it's your boy Leroy Horton and
This
my
is
good
Dr.
friend
Walter
Dr.
Aka.
Walter Aka, and we have a special guest today. It's a young man that I met in Seattle with very interesting history, which I really want to pick his brain because me and Dr. Aka, Walter, we've been talking about some issues and trying to find some clarity with what happens behind the wizard's curtains when we send something to a lab. And we here have Kyle Bennett, who's not only a doctor, but also a lab tech. Was it lab tech? Lab?
Yep, certified lab technician.
Certified lab tech for how long were you that?
20 years?
20 years. So if there's ever someone we've had on here that's an expert at anything, is this man right here. You can't do anything for 20 years and not be an expert. So Kyle, Dr. Bennett, tell us a little bit about yourself real quick.
So my name is Kyle Bennett. I'm actually from Iowa. Born in a small little town, probably like 1,200 people, and then moved to Iowa City. And there, I went to high school and did my undergrad at the University of Iowa and dental school at the University of Iowa. But before that, I went to like right out of high school, I got a scholarship for doing a lab program. And so, um, yeah, that was pretty cool. I ended up getting a full ride to that program right out of high school. But when I was 17, I started working in the lab, and then continued working in the lab while I was going to school, and um, just kept working in the lab, kept grinding away. And then eventually I ended up teaching at the college that I went to lab school for. Did that for a number of years as an adjunct. And then um, about 2015, I ended up going full circle because I ended up doing a job shadow before I decided if I wanted to be a lab tech. And so I did a job shadow at the University of Iowa with Todd Friedrich, and really loved it. And so full circle, I ended up getting that job that he was in, teaching in the prosthodontics program at the University of Iowa, helping residents with their full mouth rehabs and faculty with their full mouth rehabs, and then teaching classes for like color science and color theory to pre-doctoral students. And yeah, then I ended up meeting my wife, and she's like, "Why don't you go to dental school?" And so I had all the classes all done, and so I just applied that year and got in for that next fall. And
Nice.
that
Well,
was
listen,
last. What's
shout out
that?
to wives because
Yeah,
we
right.
do so much better for ourselves for the sake of a girl or off a
Oh,
comment or yeah. Shout out to the wives out there.
yeah. I'd probably still be a lab tech if it wasn't for her, to be honest.
There it is. There it is. So is she a dentist as well?
She is, yeah.
Oh,
So
awesome.
I was when I was teaching, she was between her second and third year doing research and stuff. But I met her on a dating app. I didn't know she was in dental school, and then we just kind of hit it off. And
Nice.
so my
Nice.
first year was her fourth year. So yeah,
That's what's up. And so when did you finish dental school?
last year. So I've been a
Last year.
year
So
out
you,
of dental school.
so you got tired of looking at these bums trying to cut teeth and take impressions. You were like, I could do that,
That's
right?
right.
So
Working in a lab, you get a variety of everything. You get those doctors that are really particular about everything, and then the ones that are just, you know, don't care that much, I guess.
Yeah.
so what do you
And this,
when it comes to these doctors that are sending you these cases in lab, so we're gonna go from the lab tech and then we're gonna go into dental. But I wanted to ask you, what was some of the trends that you were seeing? What was some of the mistakes that you were seeing, things that were happening that you were getting sent that you're like, how is this ever gonna work out?
Well, as a lab tech, you have two problems: shades and dates. That's it. Because it's either things got to turn around really quick, or the shade is off, or anything like that. And so a lot of the communication is misinterpretation of shades, right? And so that's probably the number one. It's like, oh, I need to send this back to the lab. this number 9 doesn't match number 8, and that's the hardest case to do. And as a lab tech, you prefer to see the patient, be there, do all that. And, you don't really get that chance when you're a lab tech because you're just sitting at the sidelines, just reading off a script.
So then I'm sorry, let me do a quick follow-up on that. If shade is something that's so important, why is it that we see so many patients walking around with just mismatched crowns and so forth? Like, if that's so important, why is it that literally I'll look in the mouth and I'll see like 10 different shades in the same person's mouth? And I'm like, this cannot be something the lab tech would look at and say this was great.
Yeah, and so well, there's a couple points to that. Either sending to multiple different labs, right? And so labs may have different product, right? So like GC Initial versus VM13, right? Yeah, the shades are the same, but the pigment composition is could be different, and the porcelain's layered differently from the eyes of one tech to another. The other thing is just the time, right? Patient may have got a crown 10 years ago and now they're getting another one, right? And so they could have got crowns all between that timeline.
Okay.
But
And a
would you
lot of
not
times,
match the crown that you have now
So
versus
I would,
yeah.
but like you get a patient that's like, oh, I want to bleach. Oh, I don't like this crown. I want it to be a little bit brighter, So a lot of the dictation from the patient, kind of paves the way of that mosaic of crowns.
well, one thing that I've noticed is that especially in the analog impression days, you don't even see the color a lot of the times, right? You see them
Mhm.
pour up an impression, you pour it up, and you see on the instructions, it'll say A3,
Yep.
A35. So you do A35, you may or may not have a picture to go along with it or any type of visual so you can gauge the shade. It's really sometimes, sadly to say, an assistant that's choosing the shade in a lot of offices and or a doctor that maybe using an outdated shade guide or a very minimalistic shade guide. What is the best thing you like to receive, or you liked to receive, or that you now make sure you do give a lab tech when you send in, especially an aesthetic case?
Yeah. So aesthetic cases, I strongly encourage a meeting with the lab tech and the patient, right? And so especially like let's say the doctor preps a tooth, right? And they send it to the lab. Well, the lab's like, okay, I want to see this patient. That gives the tooth a chance to rehydrate from the procedure, right? So the shade will come back to where it's actually going to be. And so that's what I would highly recommend is like get your lab really involved in those aesthetic cases and a chance to meet with like the patient had a chance to meet with the lab tech because there's a lot of important factors. Age is one of them, right? So if it's a young patient, their teeth are gonna look much different than 90-year-old grandma coming in, And so you can look at the cast and get contours and references and see like maybe some fractures and this and that and make some assumptions on where translucencies are and stuff like that. But honestly, with those aesthetic cases, get your lab involved as much as you can. And also, they'll take pictures of the smile line and see where everything actually lines up as opposed to sticking their finger over a cast and, oh, there's the smile line,
Right. Right.
And so,
So here's a question for you. And this is something that I've noticed. A lot of doctors aren't really even sending it to like their local lab, meaning that back in the day, your dentist would have a lab in the city, in the town, right? And you basically just, basically take it, pony style and take it to that lab themselves. So the lab tech or whoever will come and get the case and take it back to their lab and work on it. Now you're getting that shipped international. So it might be going overseas.
yeah.
So how can you do an aesthetic case where you just told us you need to meet with the lab when that's not the case?
Choose a different lab because those
Well, I mean, patients don't
are
have a
honestly,
choice, right?
yeah, patients don't have a choice. The doctor needs to select a different lab. I work with a couple different labs for various types of cases, and that's just there's a lot of factors at that as well. Like maybe like my bread and butter lab, right? They do really good posterior work, right? Like they just drop right in. They follow my instructions and barely ever any adjustments, which is awesome. they're great at the bread and butter. You know, their anterior work is pretty good, but I have one that I like a little bit more because they give some more vitality to the teeth. They have a little bit better contours, you know, and so in the more complex cases, you know, with implants and stuff like that, I have another lab that I like to use just because experience is another thing, you know. Like my bread and butter lab, they do implants, but like the full mouth, like all on four, you know, they don't really have the expertise for that. You know, it's just I love the small mom and pop labs. Those are the labs I worked in. Like 4-person lab, 5-person lab, they're great because there's a little bit more care there. It's not just like it's not just, you know, trying to get things in and out. But their resources are limited to doing those larger cases, so I have to find someone else that can handle that kind of load. And so it's all about lab selection. And if you're, you know, sending internationally, it's just a cost thing, right? They're just trying to save some money on those posterior cases and all that stuff, which that's all fine. You know, do what you want, just make sure you know what you're getting. You know, make sure you get you know exactly what the materials are and stuff like that, so it's safe for our patients. But that's, you know, it's all comes down to how you want to practice dentistry and the labs that you want to be working with, because they're a partner, right? I have this saying, like, my team is everybody involved, from my equipment specialist for the people that fill my equipment for my office. You know, they're all part of my team, and I want them to feel like part of the team because you get better deals. But at the same time, they're more invested, and it makes a better teamwork from that end. Same with the lab. You know, if you invest with them, work with them, they're gonna do everything that they can at the best of their ability. You know, and so select your labs appropriately, and you know, you find someone that's really hungry to do really high aesthetic work, like I was when I was like first becoming a lab tech. Like my mentor, he's colorblind, best frame-ist I ever knew, and he says, put in your 10,000 hours and you'll be good. So 10,000 hours of work, and he's always like, focus on the value because that's what sticks out the most, and then you know, bring in the hue and the chroma and all that stuff. You know, then you'll really hone in your skills as a ceramist.
Is it still profitable to own a lab? I feel like over the years I've seen so many local labs go out of business because everyone is sending out for these, you know, $50, $60 Bruxer crowns, whether it's Gladwell or you know, the Chinese company, and a lot of the mom and pop ones are priced out, right?
Yeah.
Have you seen that transition over 20 years?
Yes, I actually, one of my favorite labs that I ever worked in, like, they're not a lab anymore. They just, because of that same reason, right? Because it's all about sheer numbers to be profitable as a lab. And in this day and age, you know, you got to be able to afford some digital technology to be able to stay up and produce, right? And so, yeah, there's a lot less mom and pop places, but yeah, you just have to do sheer volume, or find doctors that are willing to pay you for really high-end aesthetics, that's willing to pay, you know, hundreds of dollars. The most I've ever seen a crown go for is like $1,000.
Oh wow.
But the lab tech is amazing, you know. So
yeah. And it's just a standard crown, or is this like a full platinum high noble crown?
That's a high end like platinum, like, you know, mostly anterior work. So, but that's just what people sought him out for it, and people were paying him to do it. And so, if you build a name for yourself like that as a lab tech, yeah, certainly you can just keep it small. But this day and age, it's all about sheer volume, because what drives the price of it down is us as doctors, right? We are faced with challenges in our own practices. You know, my wife and I, we have our office, and our biggest problem is overhead costs, right? And so where can we save? Well, if we, you know, talk to labs, be like, you know, this is a little bit out of our budget, you know, and they're always happy to be like, you know, we'll do it for this or that. Like, Okay, so there's a lot of that price gouging and competition with laboratories, you know. So when I was living in Iowa, that was the biggest thing. All these labs were competing for work for all these doctors, so everyone kept driving their prices down and down and down until now we're, you know, the zirconia crown is $125 or whatever, you know.
Right.
What would you tell a patient who doesn't know much about dentistry, right? But they just want really good work. Like, how would you be able to differentiate one office from another when it comes to the kind of work that you're going to get out of it? Would you tell the patient, hey, ask the doctor where your lab is so I can go there and make sure that my color matches? Or would you tell the patient, you know what, question them on uh the color, shade, shape, and all this other stuff. Because people are very particular. Would you say
Mhm.
go outside and get, take the shade? Like, what advice would you give a patient who doesn't know dentistry but wants really good work?
Yeah. You know, we all know that taking a shade is best on a cloudy day, right? And so,
Okay.
you know, if it's a cloudy day, I kind of talk about that and inform the patient about like ways that we take shades and stuff like that. And so when I was teaching color science and color theory, um, women are better at detecting color, right? Men are better at detecting value. It goes back to, I found this research paper on hunter gatherer, right? So men are able to see value in movement better because they need to hunt. Women need to be able to find the berries and all that stuff, so they see color better. Women have more cones than men, like cone cells in their eyes, and so women can see color better. So I always have my assistants verify, like, what do you think this is? I don't tell them what I think it is. I was like, what do you think it is, right? And so my eyes are trained for color from being an artist and all this stuff, and so I I don't know if I see color differently or better, but it's always good to have that second opinion from a woman, because I value their biology when this comes down to science, you know. And so I kind of talk briefly about that with my patients and get them like really encouraged about like the path that I want to take them on when doing these aesthetic cases. And um, I number one question that I ask them before we even get started, like, what is your expectations? What is your aesthetic desires for this? Right? And I, talk about expectations, what we can and cannot do with materials, and just kind of lay a baseline out for them, and then talk to them about the labs and stuff like that. I usually have my lab guy come in and take the shade if it's a challenging one, and then really get them to play ball with us on the same team.
Okay. One of the struggles I've had, especially now that I've been traveling from office to office, is when I have done some anterior work, I try to be very specific, right? I try to avoid monolithic,
Mm,
or for the non-dental people that might be listening, and that's a single something carved out of a single block of stone. It's not layered, right? Um, and what the resistance I run into is whatever office I'm at, because they're concerned about overhead and costs, it ends up being some tension with me as an associate and the owner over where I want to send it or what material I'm choosing, right? Have you found a way to really get the patient to buy in? So that way, especially if you're not, I mean, you and your wife own your practice, right?
yeah, we do.
Yeah. So you have that benefit, right? No one's going to
Mm.
be pulling the strings, once you leave the office. But for associates out there that have to be conscious of what their boss wants, what's a good way for us to really get the patient to buy in so we can flex the patient against the owner and get that really high-end quality aesthetic work?
Yeah. So two things. First one, I will say, maybe that office isn't a right fit for you, and maybe find a different one. Uh,
Right.
because it shouldn't be, we're here to take care of our patients, right? And so we need to educate them. Sort of the foundation of us and the patient. Educate them and get them more on board with what we're trying to do and why it's a good idea, right? Not persuade them, but educate them, and educating the patient on like what monolithic is versus what layered is versus like what a PFM would look like as opposed to like lithium disilicate or zirconia, all these different things. And really kind of, best thing is to show them and have examples, right? And then we have a bunch of examples. Like I have one cast with number 9 with every material that I could think of that I could just put on there and show patients. Right. And that's the best thing that you can do. If you can find a lab to like, hey, I got this cast of number 9. Can you make me an example of all the materials that you have? I'll pay for them, whatever. And then you can use that to show your patient. Be like, hey, this is what this looks like. This is what this looks like. This is what this looks like. This material, you can see the prep through it. So we need to adjust the color, And so really kind of.
It's a great idea, actually.
Yeah. And
that's a really good idea.
You can, that's when your patient's like, I want that one. And then you go to your boss, be like, patient said they wanted this one, man. I don't know.
Out of my hands, right?
Well, talk about insurance and how that might affect what we want versus what we can actually, what we can get based on, if the lab is going to charge us, we'll say $400 for that crown, but that crown is actually only being charged to the patient at $500. And then we talk about overhead, and we talk about how we're pretty much losing money on that crown, and doctors have to think about that.
This is interesting because, like, actually at that meeting that I met Leroy at, I went to this insurance class, and I don't know, I haven't tried it. I don't know much about it, but like you can do, what is it called? It's like a technology charge or something like that. And you have like a document that you send to the insurance. It's like, I wish I could remember what it was. It's in my notes from that, but I haven't looked back at it. But it's like this technology endorsement thing. So we'll have to look at it, but that's a way that you can actually charge the patient more to pay for those certain materials. Now the insurance company, they could deny the crown because you're using a different material because of like downgrades, right? Amalgam downgrades, yada, yada, yada. But when you have this, you send it to the insurance company and tell them the patient's willing to pay this extra technology fee, then they can't deny the crown being covered. They'll pay it at their fees, but the patient will have to pay that extra $100, $200 or whatever, right? It's kind of like if we, back in the day, we would do a full cast gold crown, right? And you can charge the patient the metal cost, right? It's kind of the same thing, but with these different materials like zirconia, right? Well, the insurance company's like, it's a zirconia crown. What's the difference? This is a zirconia crown. Why is this one more, right? Well, it's 3Y TZP or 4Y or 5Y, whatever, right? And so, you kind of talk to the patient, explain to the patient like why this material is better, but you'll have to pay the extra fee. We'll get things sent to your insurance company and then see if they'll cover the cost at their contracted fee, and then voila. So I wish I could remember the name of that form.
Right.
But yeah, sorry.
Okay.
So what are your thoughts on we're seeing, and we've interviewed a number of doctors that do, like we said, full mouth reconstructions. And a lot of these will be reconstructions that compensate not just for aesthetics, but for misalignment, for malposition, and so forth. And it just seems like all they're doing is prep. Okay, lab, do your thing.
Yeah.
Right. What trends have you seen over the 20 years as we've seen like the aesthetic market kind of explode? And what pitfalls have you seen a lot of labs and or doctors fall into with the long-term management of some of these cases that are fully rehab?
Yeah, so to the inexperienced person, dentist that wants to get into doing like full mouth rehabs and stuff like that has never had any pros training, it's great. Get some training first. Don't try to tackle it. Do a bunch of denture cases. Honestly, denture cases are going to give you that foundation of occlusion, because you need a foundation.
Walt's shaking his head. He's like,
no, I'm shaking my head because that's almost like a cuss word in dentistry. Yeah. That's how I was taught. Like when I did my GPR at the VA, I had to do, like, I spent 3 months just solely doing denture cases. I hated it, but I got so good at occlusion and understanding all that stuff. And now you tell it. Ask a dentist. I want anybody to listen to ask a dentist, how many denture cases have you done this month? I can guarantee you it's like 1 or 0.
If that.
Like even if it's 2, they're mad about it for months.
Yeah, that's because they just don't have the experience of doing it.
That's it.
Because if you're not okay, let's back up a little bit. You need to get CR, right? So even when you're doing full mouth cases, you need
Well,
to get
for anybody
CR.
that doesn't know, we just want to get you. CR is basically making sure that you're in an ideal or as normal of a position with your jaw as possible.
That's repeatable.
Repeatable. That's it. Yeah, thank you. Yeah, I just want to make sure people that are listening,
Yeah.
people that are listening, are like, what the hell did he just say? What is
Yeah.
CR? You know.
But yeah, so like if you don't have that experience of getting CR or balancing occlusion or centric occlusion or all that stuff, if you don't have a foundation of occlusion, then you need to get that before you do anything, right? Because you can destroy a patient's jaw by doing a full mouth rehab. Because if you get that TMJ off by 1 millimeter, that patient's going to hate you forever. And they're going to have bad problems later on down the road. And so, that's kind of the things that I've seen in the past is inexperienced dentists doing these large cases that that maybe they could do it in the future if they had the right training, right? I'm not saying everyone needs to go out and be a prosthodontist, because you can get that kind of training in any CE class and have a mentor, right? Kind of guide you there. But managing that many preparations, you need good tissue management to getting proper impressions. Because I used to did work for a prosthodontist back in Iowa, and it seems like he took impressions with alginate and full mouths, because I could never see a margin on that thing ever. And so that was kind of a mess. But and also another thing is what I started seeing more and more is divide and conquer, right? So if you start managing the posteriors, right, get those all good, find the vertical dimension of occlusion, so like the proper height between the upper and lower arches, get that where you want it and need it to be, and then go ahead and do anteriors, or vice versa, right? You can do the same thing with anteriors, but divide and conquer. That's always a good thing if you're trying to learn, right? You can do it a couple different ways. You can just do posteriors on one side and then the other, then anteriors, or you can do lowers, uppers, or you can do uppers and lowers at the same time. There's a whole bunch of different ways that you can divide and conquer, and that's a great way to manage patients and their expectations and really kind of hone into your skill before you go and try to prep 28 teeth, or 20 teeth with some implant supported bridges, whatever.
Well, here's a
With these
question.
bigger cases,
No, I'm sorry.
with the bigger cases, after how many years do you typically start seeing the complications? Because in my practice, I saw that you could do an all-on-4 or full mouth rehab, and everything was great at first. And it was usually around years 2 to 4, something chips here, something breaks here. Then you have to really start learning how to manage these bigger cases, which ends up being, in my opinion, was more important than learning how to do them, is how to manage the small and big complications down the road. So what's the general timeline you've seen for revisions and or revisiting some of these cases?
About the same, um, 2 years, 5 years, some make it to 10, but it's usually that 2 to 5 years where things start to chip and go wrong. Most common screws get loosened and you have to go and retighten them, but that's the least invasive. But chipping and stuff like that all comes down to a couple things. Either the lab didn't follow the parameters of the material and there's weak spots in it, or there could be manufacturing errors in the processing, or the clinician didn't balance out the occlusion correctly, so they're banging in eccentrically, when your jaw moves side to side, then it can bang in areas that it's not supposed to and cause that chipping. And so there's a lot of factors at play, but I would say 2 to 5 years. Some patients manage to get a little bit longer, and these zirconia cases that are big cases, those easily snap down the middle, And
So
but
here's something that I've always wanted to know. As technology's gotten better, we've decided to depend on technology a lot more, right? And I remember the biggest thing that a lot of these you know corporations and even private offices started using was saying you can get your tooth in a day. You guys remember hearing that? Tooth in
oh
a
yeah,
day. That was big. It was tooth in a day, tooth in a day. So we're training patients to expect their crown the same day, and they're using like Cerac and all this other stuff. And I'm not saying that's not good technology, but the funny thing is now I'm seeing a lot of that fail a lot faster. And a lot of the times, I remember we used to take bites and registration to tell a patient this is how you bite down and so forth. Now you scan and then you basically let the computer determine how the patient's biting.
right.
What do you think about that whole process? And do you think that that's why we're seeing more failures?
I mean, yes, yes, I would say so, because like crowns in a day, they're manufactured in a different way than it would be if it was sent to a laboratory, right? You get It's all about experience, right? You get the dental assistant that's scanning and designing and milling, right? They've done it for a year, 6 months, or whatever, and so they don't really know what they're doing or what they have in their hand and what they can and cannot do with that material, right? Or they you get a crown, maybe the dentist didn't prep it properly, they didn't get that 1 millimeter transfer or whatever. um, it's thin and it starts breaking in the mill, and then they just cement it anyway. I've seen that so many times,
Mm.
and so it's all about the parameters not being followed in those crowns in a day. So I have patients come to me and ask me, do you guys do crowns in a day? And I look them straight in the eye and say, no, and here's why. Right? I want a professional to make your crown. Do you want my assistant to make it, or you want a professional to make it? They're like, oh, I want a professional to make it. I'm like, okay. So I mean, that's kind of, I want to support labs as much as I can. I'm not gonna lie, one day I'll get a mill. We've been looking and stuff like that to do crowns in a day, but I'm a different breed. I can actually do that. I know what I'm looking at. I know how to prep what I'm doing. Not say dentists don't, dentists can prep. They know how to prep. They went to school, learn how to prep. But I'm not going to cut corners, is what I'm saying. And so I'm going to do what's best for the patient. And if I have a case that I could either do in a day, but if I look at it and like, yep, I'm going to send this one to a lab. This has to go to a lab because I need to manage things a little bit better, right? And so, yeah, you do definitely see a lot more failures with the crowns in a day and in-house milling and stuff like that because of the inexperience.
Mm.
Right. And so they may have did a weekend warrior class on how to, design, mill, and stain and glaze, but they don't know anything about coefficient of thermal expansion and cooling too fast from that oven causing microfractures. And then later on, patient comes back in 6 months, my crown is split in half, right? Or they didn't put in the proper cement gaps between the preparation and the crown. They put more on the occlusion, so there's more space. And now when they bite down, it's snapped in half. All these different things, They don't have that fundamental background that's required to be able to do crowns in a day. I'm
You
not
know,
dogging that. If they have that background, absolutely go for it. Do what's best for your patients. And that's what we should be doing. Do what's best for your patient. Is it best for your patient to do that crown in a day?
Well, I can tell you from experience, this is typically what happens. You own an office, a rep comes in, or you're at a convention and you're at the vendor booth. Hey, doc, don't worry. You can do this. It's fast, it's profitable. Like you said, we'll do a weekend class because it's that easy,
Mhm.
right? And before you know it, you'll be milling these left and right. And now the doctor translates that to the assistant over maybe like a half-hour conversation of, hey, this is how you choose your margins, this is the buttons that you press, boom. Because for us to be sitting down and to be choosing our margins and designing the crown, that's eating up our what we call chair time, right?
Right.
It's not as productive. So we often kick that off to someone that's supposed to be trained, but usually it's a kind of flash by night tutorial that we give them.
Mhm.
What do you think we need to do as a profession to stave off this kind of infiltration from the sales reps and the big companies that are convincing us we can do anything with computers extremely easy, fast? and we're eliminating some of these experts like the lab technicians and the ceramists. What do we need to do as a profession to kind of protect ourselves from that influence?
Well, so as an owner, right? If you're going to do that, like let's say for me, right? So if a sales rep manages to convince me to buy a mill, right? Then it's up to me as a business owner, a dentist, to make sure that my staff is well trained and understands what it is that they're doing and why they're doing the things that they're doing. Just like if I was a trained dental assistant off the streets, right? I don't just tell them what they are doing and what they need to do. I give them the why, because that's more important than what it is that they're doing. Because if they understand the why, they can do what they need to do, right? And the same thing with these doing crowns in the day and stuff like that. They need to understand the why. And so it's going to be best for our profession if you lay that foundation, in your team, right? And really educate them. And, if they can't get it, then you get them the help to be able to do it, right? And so the other thing is maybe you should stay away from doing that. Maybe it's not a good fit for your office, and really do your research and see if it's something that is good for your patients, right? And not just profitable. Yeah, we want to make money. We want to keep our office float, pay overhead, all that stuff. But it shouldn't just be about making money and saving money for the office. You got to do what's best for your patients. And so if it's not a good fit, don't do it, right? And if you feel like it's just going to, you have this assistant that really wants to learn how to do it, then, you give them the training, all that stuff. And so if it's to look out for a profession, just, take them to school, teach them, educate them, and make sure you're doing it right. Don't cut corners. As an educator, that's really, really important. So, that's going to be what's best for our profession in that nature, right? It's why we have to take CE courses. It's why we have to take so many. I think we have to do 63 credit hours every 3 years.
Every 3 years. Yeah.
As a lab tech,
I just
need 12.
I'm gonna tell you, you've lost a lot of doctors just listening to you, because you're asking them to do things that they don't even want to do. Read, learn, and continue to learn. No, I'm telling you that right now. We lost.
Yeah.
I bet you people turned this podcast off already.
No.
Because you're challenging them to do things that they don't feel comfortable doing.
But Walter, let me ask you this.
Yeah.
Let me put a question towards you.
Please.
So a lot of docs don't want to do that.
Nope.
They're busy kind of living their life, trying to make money, pay off
I can
their
guarantee
debt.
they don't even know what the materials that they have do. I'm promising you on that.
Oh yeah,
Right.
no, for sure.
So should we regulate more? For instance, Oregon passed a rule saying that if you're a general dentist doing implants, you have to have at least 80 CE training hours before your license is allowed, right? Should we start regulating the technology and say, if you're going to be doing Invisalign, if you're going to be doing in-house milling or 3D printing, there should be X amount of documented training hours, however you want to build that regulation, since we know that if the alternative is a rep saying, hey, here's some 8 hours of CE you can do in your own time on your computer, they may or may not be listening while that's running in the background.
Right.
Should we regulate the training more, or should dental school be longer? What's the answer to that?
Well, dental school shouldn't be longer.
He said no. He said it should. He said it should not be longer. And I agree. Actually, dental school being longer is basically saying you want to go to jail longer. No, it doesn't. You don't learn crap. I'll be honest. You know how I feel about dental school. You learn dental school gets you out so you don't hurt people. That's all you learn from dental school. You are barely competent. And I'm going to say that with and I'm going to say that with all disrespect. You are barely competent. You are barely competent to come out. When you come out of dental school, you are barely competent. Most people become really good 2 ways. Either you just naturally just inquisitive and want to learn more, or you take a heck of a lot of CE courses and you develop your skills. And you're not ashamed to ask people for help. But dental school is not where you're going to become great. I can guarantee you that. Period. Point blank. Full stop. Right. Another thing that's scary. You mentioned regulation. Ready? I had a conversation with two doctors today, and they're like, "Hey, did you notice that our X-ray system or X-ray software now has AI?" And I was like, "What does that mean?" And they're like, "Yeah, it tells us where the caries are and bone loss, and it shades it in different colors and so forth." And I was like, "Oh, that's what's up." And I was like, "Do you agree with where the AI was telling you what caries was?" And she was like, "No, no, that was horrible for that, because it would even mark like burnouts as caries lesions." And I was like, "So you saw this?" She's like, "Yeah. But it's really good for bone loss and calculus." And I was like, if you have to use AI to tell you where calculus is, isn't that concerning to you? And they both looked at me so confused, and I was like, "Never mind." And I walked out because I was like, "You clearly missed my whole point, which was you don't need the computer to tell you something that you should already know." But that's the
Right.
same way. And I use that example as to say that if you basically just kept up with, the ADA magazines or the journal articles or whatever, you would actually know more and be able to be more, you would actually be able to critique, reps that come into your office to know what's BS and what's bullshit versus what's actually legitimate good science, right? Because now we can all sit here and read an article and say, "Oh, this is a waste of my time. Throw it away." Because we know that it's tainted in, because the company that paid for it is basically wanting that result to fit what their narrative, right? This is the problem. It's people are lazy and don't want to challenge anything. So regulations, they're going to find ways to get around the regulation. You can say you need 80 hours, and the rep is going to come and say, "I got 80 hours for you if you sit there for 4 minutes." Like, they'll figure a way, right? Like, everything is based on money. The Dent Supply is going to say, "I want to sell this machine. I need these doctors to buy this machine. So if it takes 80 hours, sure, I'll give them 80 hours. Watch this video. I don't care if you have it running for the whole weekend and you're not even sitting in front. I'm going to give you that." So regulation is going to do what?
All this doom and gloom, man, you're getting me depressed.
Oh man, I want you to be
What are we
depressed. I've given up the hope of dentistry because I'm seeing this. And I joke around, and we wouldn't be doing this if we didn't love it. But it's really, I'm becoming disheartened because there's so much things that I'm just like, if you just thought this through, you'd be great. But people have become lazier as social media and everything has kicked into full gear.
Okay. Well,
And we
let's
see
ask
that. We
Kyle.
see that, right? Let's talk about social media, because you and I, we talked about this all the
Yeah.
time, Horton.
Yeah. So Kyle, when it comes to social media, do you feel like that is a major culprit in kind of this culture of we want expedient results, expedient abilities without the time and the training and the study? Um,
And
what do you
everybody's
what do
an
you think
aesthetic
social
dentist, by the
media
way.
plays
Yeah.
in?
Yeah.
Yeah.
So, it has on both ends of the coin, right? So one end, you have social media driving this different types of work and stuff like that, and really motivating young dentists to do the things that they want to do, and so they follow over social media, and then they get educated on it through social media, and then they find the avenue of learning more things along the way. Maybe they read this article, they go take the CE course because social media has really kind of pushed them over to their niche. So that's a great thing, but at the same time, you get people that aren't that motivated, then they see this one time, like, I can do that, you know? And so,
YouTube it is.
yeah, right. Like I YouTube to build stuff, but not practice on my patients, Um, but so it's kind of, it's in the eye of the beholder, so it can really do some good for these young dentists. And I look at a lot of social media and see stuff like, oh, I could do that.
Mhm.
I could do that better, or all these different things.
But the difference is you have 20 years that actually proves that you could do better. These
Yeah.
people are just graduating and think they can
Yeah.
do better. Do you see what I'm saying?
Yeah. And so, but at the same time, when I was that young, going to all these, like when I was right out of tech school, I went to so many CE courses. Like I was taking like 100 CE courses a year. I was in it because that's what I wanted to do. And so I was learning all kinds of stuff. And so, really, but back then there wasn't social media 20 years ago. And so,
No, don't say that out loud. We're in the same generation, man. Come on, you're making us look bad. Those Facebook. We had
yeah.
likes.
No, it was MySpace.
MySpace, yes, yes.
But social media has really kind of driven the market in all kinds of different ways, and
Right.
it's kind of whichever direction you let it take you is it can take you down a rabbit hole in two different ways, or you just don't even pay attention to it and don't
Well,
let
do you
social media
think that
drive you.
social media is overall good for dentistry with influencers? Like now we have dental influencers. We know people who are dental influencers. We know people who want to be dental influencers. We got young guys that come up wanting to idolize the dental influencers. So do you think social media is actually good for dentistry?
So yes and no. Yes, because it gets all that education out there,
Is
right?
it
And
education?
well, so
Right? No, is it education is
I
you're
mean,
sitting there
it's
and you're actually basing everything off of
information,
science.
information.
My
There we
man,
go,
it's information.
information.
Okay.
And
Okay.
so it gets a lot of information out there, whether it's positive or negative. Like the negative side, patients see this and be like, I want that. I don't care. I want that. Well, you don't really qualify for that because it puts you at risk for this, that, and the other thing. And so it's bad in that sense when just the regular person sees all that dental stuff, it's like, oh, I, watch this social media thing about fluoride. I don't want to do fluoride anymore,
Root canals.
root canals, right? And so, I have to pull out like information of studies about root canals all the time because the root cause.
Right.
Goddamn Netflix.
Yeah. And
So Kyle, you just graduated not too long ago. You've got this, you've got the advantage of kind of age, experience, and maturity to contextualize all the stuff you were learning recently in dental school.
mhm.
Do you feel, or how would you rate the job a dental school does, or the institution of dental education does at really inspiring young dentists to develop a passion and a desire to take those CE courses, better themselves, to be disciplined enough to get the reps in and the clinical practice in? Or do you see that dental education itself has become a farm of how many can we just put out? How many
Yeah.
dentists can we produce? Well, what did you walk away with since we're in the same generation and you have more context to gauge what you went through?
So dental school was very interesting for me because like I knew everyone that I was there. The University of Iowa has a really, really good dental program for the general dentist, right? And so there's a lot of top-notch instructors there, like Clark Stanford, he's the dean there, and he's like a really good, well-known prosthodontist. Um, and then so there's a lot of heavy lifters there that really like drive these students to want to do various different things. And at our dental school, they really encourage technology. So right from D1 year, students are scanning and learning how to scan and prepping based on how to scan, and all this different stuff. And even D2 year, they were using I think they were using Blue Sky Bio to kind of messing with implants and
Implants. Yep.
CBCTs,
Yeah,
right?
I
And
use
that's
bio.
yeah, and that's in D2 dental school, like, and that's pretty awesome. And so we had a lot of faculty that were really encouraging students to follow the path that they wanted to. If they wanted to do oral surgery, or if they wanted to do aesthetics, or if they wanted to do digital, or if they wanted to do this and that, everyone had someone to go to if they really wanted it. And it comes down to the individual if they really wanted it. Some students, they just want to get in and get out, right? And so, and a lot of dental schools are really trying to increase their student population, but are limited by the facilities.
Right.
And so you see a lot of private schools coming up, and they're just in it for the money. So they're just like packing people in these classes and having educators that maybe don't have the most experience yet, teaching these classes, which is fine. You got to start somewhere, and it's great. But it's if you're just trying to pack the numbers, and it's probably not the best idea for a student's education. But I think it's, it all comes down to the dental school that you go to, because I mean, did you guys go to the same dental school?
No.
No,
Yeah.
no. I went to
I went,
University of Washington, and he went to
I went University of Pittsburgh.
Okay. Yeah. So, I mean, we're all across the state,
Right.
literally, right? And so we got East Coast, West Coast, Midwest, right?
That's right.
And the philosophies are so much different in all those programs that, and the educators in those programs are so much different. And so it's all about the mentors in those programs that really kind of drive those students to really do the things that they wanted. I know there's one girl in my class, every crown that she was doing, she was scanning that thing. She was just like, I want to learn this, So I tried to get the scanner checked out for one of my patients, and there she has it. All right. So, but, and
which does get us back to, as you're saying, what the responsibility of school has and the culture they set up and the environment, right?
Yeah.
And me and Walt I always joke that dental school should be longer, primarily because I want to say the first dental school in the US anyway was like mid 1800s.
Yeah,
right?
Maryland.
And I want to say it was like 3 years.
Right, Maryland, yeah.
Right? Here we are, we've got 150, 160 years worth of more knowledge, more skill, more technology, and we're still only 4 years.
Right.
As a minimum, right?
Right.
So do you feel, if let's say we took cost out of it, let's say dental school was free, do you think there would be a benefit to maybe either mandatory residency, and we can call it a paid residency, right? So people can like it more, or just increasing the school size? Because there is so much to learn. I just felt like in 4 years, even the better schools, within the right context, you might have benefited, or we might have all benefited from one more year of school.
Mm-hmm. Yeah, so it's kind of interesting. So, I mean, med school, you have to go to residency. You don't have a choice.
Yep.
Right? So what makes it different than dental school?
I agree.
When it comes to that, right?
I agree.
Even if it's just, if someone goes to med school and they just want to do general practice, they still have to do a residency for that.
At least 1 year.
Yeah. And so, dental school is a long time, another year.
I know,
but at the same time, it flew by so fast, And so, I mean, another year, I graduate now. It's kind of hard to say because, yeah, we would totally benefit from another year. But at the same time, I took biochemistry in undergrad. Why do I need to take it again?
Right.
I took microbiology in undergrad. Why do I need to take it again? Right. And so maybe kind of weed some of those courses out and make it a requirement before going into dental school.
Makes sense.
Because each dental school has various different requirements.
Makes sense.
Right. And those two classes are some of the biggest ones between dental school. Oh, you don't need this, you'll take it there. Or you need to have it because you're going to take a harder one there. But maybe weed out some of those, because what was one of the first things they took out in dental school? You don't need to do any of the lab stuff anymore. Like back in the day, at Iowa, you used to have to wax, cast, and finish your gold.
Wait a minute, they don't do lab stuff anymore?
I mean, you pour casts and stuff like that, but when it comes down to waxing, you just wax your first year for dental anatomy. But after that,
what you don't have to buy your own gold anymore and crucible and
melt it down. Well, let me ask you my last question, and I'm not asking you this so that you get in trouble. I'm not asking you this so that you you don't want to come back on or anything, but I have to ask you this, and I would ask myself this. I've asked myself this. How many people were in your class?
So this is interesting. Like when it first started.
Well, let's say how many people graduated.
Well, so this is why I say it gets interesting, because I think it was like 76.
Okay.
But then when we started our third year,
advanced
Iowa started an international program, so they would
Right.
bring in 4 new international students
Okay.
that third year.
So 80.
So yeah, roughly
80.
80.
That's how
Yep.
it was at Pitt, right?
Okay.
So out of the 80, how many would you trust to do dental work on you? No, I mean, I've asked that question to all my friends,
Like
and
right
we
out of
all
dental
know the real,
school.
like you know your class.
Valid question.
So most of my patients were people in the dental school.
Well, how many
But
out of the 80 would
I don't know.
you
I don't
trust to
know.
do work on you?
Okay, so right, like in dental school, what year in dental school?
I'm talking about in your class.
Like
You
right now,
graduated
though.
with 80 people, including yourself, 79 people you graduated with.
The
How
day
many
after
of them?
graduation, you need
Day
a
after
root
graduation.
canal.
Okay, there we go.
Yeah,
Graduation.
after graduation, you need work done. How many of those people, the 79, would you trust to do work on you?
Probably about 5.
You basically summed up what I've been saying. And it stands for me too. It
Yeah.
stands for me too. And Horton, how many would you trust?
I would probably say roughly the same. Sadly, and it's not because I feel like the other 95% would do damage. It's just once you've seen it and you know what it entails,
That's it.
you want slightly more, even if it's not, if I wouldn't categorize it as gifted hands, you want the people with the character to always want to do their best in the moment.
That's it.
Yeah.
That's not uniform. That type of integrity and willing or desire to at least strive for greatness is not uniform
That's
in
right.
any program, let them, let alone dentistry, but in any program. So I would agree with that. Five
Right.
to
Yeah.
10 at the most. Yeah.
And that's what I'm getting at is in the end, we all graduate, but we don't even trust the people we graduate to do the work on us. Right. And that speaks to why you need an extra year or 2 or 3 or 4, depending on who you are. Because in the end, they graduate enough to basically be competent, but not good. Definitely not great. There's
I
very
mean,
select few people that are great.
there's some that I wouldn't even let touch my mouth. So
There you go.
even after those years of experience, like that's not gonna. It's sorry, it's not gonna do it.
That's it. And that's what I'm getting. But the sad part about it is patients don't know this,
Right.
right? Those are those are people that are out there right now working because they became dentists. Patients don't know this. And if they're smart, they're going to go on social media and they're going to get really good at social media algorithms and so forth. And then people are going to want to go to them. And we're looking and going, this is horrible work. But patients don't know any better.
Yeah.
Right.
That's my biggest beef with dentistry right now.
Yeah, and that's why that's the exact reason why I like to educate my patients and let them know that I have that compassion for them, and that kind of sets me apart from because I don't want to sell dentistry, and that's what a lot of people do.
But that's what
Which is
everybody says to
fine,
do. You got to sell dentistry.
Yeah, but you
right?
can sell it with a kind heart, and so yeah, like if I have a patient, right, and they need a crown, but if their budget isn't for it, like okay, well watch this, well it's not like you need to have this crown right now, but let's just keep an eye on it. We'll take care of you. We'll do everything we can, but you got to do your part at home too. You need to go to oral hygiene, all this stuff, and really educate them and show them that compassion. Now they're going to go and tell their friends, and friends, and so I'm going to get some new patients that way. So it's not selling in the moment to get that one crown, but like I just got 5 new patients because I was being nice to my patient as I should be,
Man,
and
you
like
got me
educate.
you got me asking one more question. Do you have that mindset because you're the owner of the practice, or do you have that mindset? Do you think that associates who don't have any stake in the game have the same mindset you have? You said
No.
you don't need to sell it for right now, right? I believe that associates look at it as I need that revenue now. What do you think, Horton?
Hold
I
on.
honestly, one of the things that I struggle with is associates. I feel so bad for them because I was an associate before I was an owner.
Right.
I was an owner, now I'm an associate again, right? And I know what it's like to have a boss that's breathing down your neck,
Right.
that's telling you you need to produce more, you need to make more, you need to see more
Mhm.
patients, you need to push more CEREC. Everything should be CEREC. We don't
That's
do MOD deposits, we do MOD CEREC inlays.
inlays,
Right?
onlays. Yep.
And you got all these young dentists that are being hired by DSOs that are
Yep.
driven by this squeezing an extra percentage of profit,
Come on.
in every office.
Come on.
And so I do almost envy Kyle because Kyle owns his own office. And it was so nice to control the systems, and my system was absolutely a compromise between what do we do that's best for the patients, educate the patients,
Right.
what allows us to do the best possible job. But when you're an associate, and it's hard out there nowadays for these associates because you got $800,000 worth of school debt, and you got PDS or Heartland or and any other of these DSOs that it's not about everything Kyle just said, because Kyle's articulated a wonderful philosophy on how to treat patients
Right. How to
and
treat people.
how to treat people.
Mhm.
And that's what I fear for a lot of the young dentists is that
That's it.
that is not the culture in especially in corporate dentistry at
I
all.
agree.
Yeah, no,
I
not at
agree.
all. So, when I was in dental school, I got my distinction in dental public health, because I love treating patients. This is what I was meant to do, right? And so that compassion's just been with me since I was little, and it's something that should be taught more in dental school, but it's also just an individual thing, and so like my favorite patients are I love doing pedo. Like
Mm,
I could talk Superman and Marvel all day long with these guys, and it's
mm.
so much fun, right? And I see Medicaid patients because I just want to take care of these kiddos, right? And so, um, it's I just want to do my part because a lot of practices don't want to see Medicaid,
Yep.
and so that's why other offices are either stuck seeing a bunch of Medicaid or not. They just cut it off for whatever reason. But I don't know. I think if everyone did like 5% Medicaid, then we'd all share the load, and it would be great. But everyone's philosophy is much different, and so I see about. Mm, my wife sees mostly the private insurance, and I see mostly like the big cases, surgery, and pedo kids for Medicaid. So we have our different niches because it's the way that we like to practice, right? And so um, it's just like just my own personal preference and how I want to practice dentistry.
Nice. Well, that's a good summary, man. That's a good
Absolutely.
summary. Horton, let's close out, man.
Yes. Well, listen, Kyle Bennett, where are you located now?
I am in Vancouver, Washington. I love it
Vancouver,
out here.
Washington. Great, great. So for anyone listening, you got an amazing, compassionate,
That's it.
and highly skilled
Mm-hmm.
because of that 20-year history with materials dentist in Vancouver, Washington. So definitely, if you're in that area, check out Kyle Bennett. And what's your wife's name?
Dr. Erica Takanami.
Erica Takanami. What's your clinic name?
Yep.
Lighthouse Dental.
Lighthouse
Lighthouse Dental.
Dental. Look
And,
for the
and
light.
my Instagram is at dentist more or less.
Nice. Well, listen, brother, we thank you so much for coming and
Yes.
sharing some of that knowledge and sharing the characters. I think we try to highlight not just science, not just treatments, not just, kind of dentist talk,
Mhm.
but it's always nice to have someone whose character shines behind the words that they're saying within this small amount of time that we're talking.
Very true.
And so I appreciate you, giving us insight into how you think, how you are, and letting people know you can be compassionate and successful.
Mm.
Those two can go hand in hand. So we appreciate you coming on, brother. Walter, we're going to see each other pretty soon here in sunny Las Vegas for a great debate. So
It's gonna
I'm
be hot
looking.
Las Vegas, I bet you.
Yeah.
It's gonna be hot Las. You can't see it's gonna be hot
Well,
Las Vegas.
well, it's definitely going to be hot in the debate because I'm turning that fire up. Okay, I hope
Yeah.
you're ready. I hope you're ready. Kyle,
I
Kyle has seen me in action. I am
Yeah.
so amped and ready for this.
I,
Kyle, if
I'm
you
gonna
have
tell you right now. All this talk is basically how Biden said he was gonna come ready. He was gonna be prepared, and then he fell asleep. So, I, and I believe you're older than me. So we gotta go ahead and let's put it out there.
I am. Oh my gosh, I'm the old man in the group. Well, everybody, thank you for tuning in.
Yeah.
And we check out our next episode that'll be dropping soon. And do check us out in Las Vegas if you're a dentist or a dental staff and you want to come to the National Dental Association convention. And we'll talk to everybody soon.
Yeah.
Thanks for having me, guys. Really appreciate the opportunity. It's been super fun. Really like doing it. So,
Kyle, thank
Absolutely,
you,
we'll
man,
bring
for
you
coming
back, my
through,
man.
brother.
all right.
All
Thank
man.
you.
Enjoy. Thank you for listening to this episode of Truth Be Told. The opinions on this episode are just that, our opinions. Please consult your dental professional before taking any action with your dental health. If you have any questions about anything you heard on this episode, please contact us at Real Dentist with an S. That's REAL Dentist with an S at gmail.com. We would be very happy to return any message that we receive because we love the communication that we have with our listeners.